Oh, hey, Sindura.
Hi, Beverly. Can you hear me okay?
Yes. So- Okay. Hello, everyone. My name is Beverly Chang. I am an endocrinologist at Weill Cornell Medicine and one of the co-founders of Tri-State Obesity Society. Thank you for giving us your time this evening and joining our two wonderful speakers on learning more about obesity pharmacotherapy. I'm just going to give a brief introduction to the two speakers and then hand the floor over to Dr. Kohli here. Dr. Sindura Kohli is a hospitalist at Northwell Health. She completed her clinical obesity fellowship at NYU and is double board certified in internal medicine and obesity medicine. She has written multiple textbook chapters, research, given grand round lectures, etc., on topics within obesity and gastroenterology. And in 2021, she was awarded the Naomi Nakao Gender-Based Research Award by the American College of Gastroenterology for her work in fatty liver and PCOS. She currently serves as the co-director for the program committee for us, for the Tri-State Obesity Society, and continues to educate people within the hospital and in underserved communities about the importance of prevention in chronic medical conditions. And then our second speaker is Holly Lofton. She is a clinical associate professor of medicine at NYU and is she designed the New You program at NYU. She is also on the advisory board and board of directors for the Obesity Action Coalition and is a principal investigator on several obesity pharmacotherapy trials, wherein her research interests include weight regain after bariatric surgery, PCOS, and non-alcoholic steatohepatitis. She educates students, residents, fellows at the NYU School of Medicine with regards to people with obesity and also serves as the medical director of the NFL Alumni Wellness Challenge. So we'll go through the lectures. If you have any questions, feel free to unmute yourself, interrupt and ask your question. Or if you don't want to interrupt the flow, you can just throw the question in the chat and we'll hopefully have time at the end to answer your questions.
Thank you. And I don't always see the chat, but Beverly, please feel free to stop me if a question pops up. Happy to just answer it right then and there. Sometimes it's a little bit easier. Thank you so much for everybody coming and just being interested in obesity. We need you. We need people that are addressing obesity in every role that you're currently in. So we're gonna start with disclosures. I have no financial disclosures. Dr. Lofton does research with Eli Lilly and Novo Nordisk. So she does get funded by them, as well as speaking honorarium and consulting with Novo. So this lecture, we're going to talk about evaluation of patients in deciding pharmacotherapy, understanding the pathophysiology of these medications, going over FDA-approved medications. We're just going to mention the off-label medications. However, this is a CME approved lecture, so they'll just be mentioned and we won't be going into them. We're going to talk about medications that are in the pipeline, new and upcoming, and then resources for further education. This slide, the animation's not working for some reason, but it was to talk about the prevalence of obesity in adults and how it is. If it was working, you'd see that the percentage of obesity in developing countries has grown in the past 30 years, more so in the last 10 years. So obesity is a worldwide pandemic, and it needs to be addressed in many ways because of its effect and its role in chronic medical conditions. The pathophysiology, this is great for clinicians, but also to be able to explain it to some of your patients that are more involved in their care and more interested. So there are two main pathways that we're going to address, which is the POMC-CART pathway. I don't know if you can see my pointer, but you can see this green pathway is the POMC-CART. And then there is the NPY-AGRP pathway. So there's different signaling mechanisms, such as your stomach, your pancreas, and then or fatty tissue. They release different hormones such as insulin, leptin, ghrelin, which either activate or inhibit these pathways. When the POMC-CART pathway is activated, it actually will decrease your food intake. So it's an anorexigenic pathway. Now, these pathways are in the third ventricle of the brain, and then they send their messages downstream to neurons, and then overall will decrease your food intake. Then you have the orexigenic pathway, which is the AGRP and NPY pathway. So ghrelin, for example, when you eat and it releases, when it releases leptin, when you eat something and then you release insulin, then it will inhibit this pathway. And then instead of increasing your food intake, it'll note that you're full, and then that's why this pathway is inhibited. Then same if you are not eating anything, then it gets activated, and then that increases your food intake. So any sort of disturbances in either of these pathways will lend you towards either overeating or undereating, or just a balance between the both is ideal. Medications do play a role in altering these hormones that are released, as well as pathways down the line, such as MC4R, which you can see on the neuron level. And then genetic diseases are due to disturbances in some of these receptors, such as more famously the MC4R1. So when you are evaluating patients, these initial visits are usually much longer than when they're here for internal medicine. So usually the initial visit is sometimes 45 to 60 minutes, and it really establishes a baseline that you need to understand what exactly we're addressing in these patients. So when we take this medical history, it's more structured towards obesity. So what obesity-related comorbidities they have. When we talk about previous surgeries, we're focused on if they've had previous bariatric surgeries, if they still have their gallbladder or not, because when you do have rapid weight loss, you're prone to gallstones. So sometimes these patients get ursodeal pre-op or when they start having abdominal pain, that's a initial differential that you want to rule out. And then also if they've had knee or hip replacement, those are all indications that they have a heavy load on their weight-bearing joints, and sometimes that can help in terms of getting patients approved for medications by letting companies know that these are all medical conditions that need to be addressed. When we talk about weight history, you want to note the onset of obesity, whether that is in childhood or adulthood. It does change. Or whether it's like very recent, so in the last few months. Knowing that allows you to address patient expectations. You want to note the rate of weight gain, current or history of eating disorders. It's important that we're not abetting somebody who has anorexia by giving them medications that suppress their appetite. Methods used in previous weight loss attempts, and nutrition. An easy way to do this, so that way you don't get a distorted food diary, is just asking them to note down what they ate in the last 24 hours. Just a quick 24-hour food recall. Their activity level, and then medications that cause weight gain, which we will go into in later slides. Social history. This is important, and then it's sometimes not always addressed, but I think this is one of the most important things that you can take from a patient. So their socioeconomic status. I've had patients, for example, I tell them a food plan, and then at the end they would tell me they don't have a refrigerator, or they don't have an oven, they don't have running water. So that's really important to note beforehand, and then you can figure out a plan that is actually feasible for them. Stressors or life events, recent divorces or deaths, those are all big things in people's lives that can alter their eating habits, that can cause weight gain, that can also change their compliance and mindset, and if they want to really start a plan right now, or give it some time. Social habits, is this patient about to quit smoking, which is associated with a transient weight gain? Are they big alcohol users? And then sleep is really important, which is related to circadian rhythm. So if somebody is a night shift worker, they're known to also gain weight. There's studies in Japan that show that night shift workers, even when they ate very clean, they still gained weight and still had obesity-related comorbidities. Oh, I'm sorry. Are you able to? Sorry. Were you able to see my screen? Okay. So they've shown that they still gain weight because there's a change on a mitochondrial level. And then their place of residence from the clinic. So you want to see how often they can make these appointments, because you start a long-term relationship with the patients. And so they need to come monthly, sometimes every 2 weeks, depending on what sort of plan you place them on. And that in turn, also you want to know their telehealth capabilities in order to kind of make sure they're compliant with making their appointments. I did notice that there is a question. Sorry, I'm trying to access the chat.
Dr.
Sorry.
Coley?
Yeah, sorry, I'm not able to see the chat.
Dr. Coley, can you hear me, Dr. Coley?
Yes.
This is Holly Lawson. How are you? I can read the question.
You can read the question. I'm sorry.
Would you like me to read the question for you?
Oh, yeah, sure.
The question is from Dr. Katz. The question is, do you do nutrition education and evaluation of eating habits for each patient, or do you defer this to your experienced dietitian? This is in the context of being able to stay within the 40 to 45-minute initial consult. Why are you working on the slides? I can answer that. That's okay. I apologize for being late. I got the time wrong. I was in a car. So I do some initial nutrition education and evaluation, and then depending on the patient's preference, either let the medical staff continue to do the nutrition education at the future visits, or the patient wants more comprehensive recommendations or plans involving meal replacement, for example, we then defer those to the dietitian so that they can have more personalized care. And different practices do it differently. I welcome others to chime in on that. But within the consult, I do get a diet recall, as well as give the nutrition recommendations in addition to the medication recommendations and the expectations. So yeah, do that within 40 minutes.
Yeah, I agree. I mean, I think starting some tips in addressing some of the issues that you might notice on their 24-hour recall in that first visit, I think is good and important. Starting with a small step here or there, such as decreasing juice or soda intake, things like that, that I think that are small and you can build upon with each visit, and that they can build upon with their nutritionist, and see what barriers that they might have just when they embark on that first initial step, and that it can be addressed at each visit. I think there's another question. I have no idea why the chat is not opening for me. Is there another question?
That is the only question for right now.
Okay. Did you want to take over, Holly, or continue, whatever you prefer?
Sure, I can take over. Okay. And if you don't mind advancing the slides for me, that'd be great.
Yeah.
Holly, do you think you can get closer to the mic? You're a little blurry, I think.
Okay. Okay, I'm using a headset. I might just use the phone as the.
No problem. I can do this
Okay.
slide.
Yeah,
Okay.
Holly, why don't
Thank
you see if you can get into a quieter place or a stronger audio, and we'll have Cinder continue for now until you get back on.
Okay, no problem. Thanks.
Okay.
Thanks. So we talked earlier about getting their medications and understanding which medications are associated with weight gain. And there's a lot that as clinicians you might be familiar with, such as antidepressants, or antipsychotics or steroids and contraceptives. Those are all well known to be associated with weight gain, but I think it's also eye-opening to see some of these medications such as beta blockers, such as antihistamines, such as insulin are associated with weight gain. And I've had many people argue about insulin that it isn't, but it is, unfortunately. And what's important about that is that they're all alternatives. And so if you do recommend that these patients see the prescriber that is giving them these medications, whether it is their psychiatrist, their cardiologist or endocrinologist or PCP, and let them be evaluated to see if they can go on an alternative or be tapered down on these current medications. And then things such as antihistamines, you can just, most of the time patients do just stop them and realize they don't actually need them. So these are good to let your patient be aware of them, and so many of them are grateful for this. So physical exam, this is important to establish a baseline. You're looking for any signs associated with genetic causes of obesity. You're looking to know obesity-related comorbidities, diabetes, sleep apnea, any sort of osteoarthritis as well, patterns of fat distribution. This is also important because you do want to make sure that patients don't have lipedema, which you can see in these pictures is an abnormal accumulation of adipose tissue in their lower bodies. So this type of fat accumulation is hard to treat with just diet and medications alone. Most of the time, these patients will end up requiring liposuction. So I think it's good to address this so they know that they're not failing the medications, they're not failing the procedures. It's just that the medications and procedures are failing them because this is something that can only be addressed with liposuction. I've seen some meds help in a little bit, but they have a lower rate of efficacy. And then you want to note mechanical consequences of obesity. This is more in terms of osteoarthritis, where you do see the loss of cartilage, et cetera. Blood work, you want to establish a baseline, so CBC, comprehensive metabolic panel that will include the LFTs, so you can start assessing for NAFLD, their A1C, lipid panel, and TSH to make sure that their weight gain, for example, is not because of hypothyroidism. Body composition, waist circumference to hip circumference, you want to assess that ratio because it is associated with heart disease. You want to get their BMI as well. For insurance purposes, that allows also for approval of medications, their heart rate and blood pressure as a baseline, and you'll see why when we go into the medications. So we come to pharmacotherapy. So what are the indications? This can be prescribed in patients that have a BMI higher than 30, or if their BMI is higher than 27, but they have obesity-related comorbidities such as diabetes, hypertension, OSA. So it also can be used in those that have not achieved their target weight loss following bariatric surgery or endoscopy, because there are now endoscopic procedures that can make the stomach smaller and then also allow for weight loss, or if they've regained weight after these surgical or endoscopic therapies. So the FDA approved medications, you can see we have a handful. We have phentermine, topiramate, orlistat, naltrexone, bupropion. We have the GLP-1s, liraglutide 3 milligrams, and then semaglutide at 2.4 milligrams, and then setmelanotide. So diabetes medications with the side effect of weight loss, these come under off-label medications. So these are indicated specifically for those with diabetes. So if a patient is having trouble getting approved for other medications, but they have diabetes, these are some good options to give. So you have metformin, SGLT2 inhibitors, pramlintide, and then GLP-1 receptor agonists other than liraglutide at the 3 milligram dose or semaglutide at the 2.4 milligram dose. When you're assessing efficacy, each of these medications, their pharmaceutical companies will note what is considered efficacious for each of these medications. When do we just stop them? When do we switch them? When do we add medications? But most of the time, efficacy will be defined kind of broadly as if they've had more or equal to 5% total body weight loss over 3 months of consistent use. So we're going to go into just a clinical case. It's a 30-year-old female with a BMI of 32 who presents for weight management after minimal weight loss with diet and exercise. Past medical history includes knee osteoarthritis. Current meds that she's taking are Tylenol and oral contraceptives. Family history, mom has hypothyroidism, father has lung cancer. Social history, no alcohol, smoking, or drugs. Teacher lives alone, insurance recently lapsed, so no medication coverage. Review of systems, positive for weight increase, hunger, knee pain, no chest pain or palpitations. You can see that the vitals are all normal. Weight is 205 pounds. Cardiopulmonary exam is normal, and EKG is normal sinus rhythm. A heart rate of 80, and QTC is 450, which is normal. And then I'm going to see if Holly is on.
Hello.
Oh, perfect.
Does my audio sound any better now?
Yeah.
Okay. All right, great. Thanks again. Sorry for the being late. So we'll move on to talk about some of the more specific medications. We'll sort of go in order of chronology tonight and talk about mechanism of action, the effects as far as total body weight loss over time in the trial, some of the adverse effects, contraindication, how to dose these meds. So phentermine, mechanism of action, is a norepinephrine releasing agent. It's commonly known as an appetite suppressant, but it also has an adrenergic activity. And the total body weight loss seen was about 6% with 15 milligrams versus about 2% with placebo. And we know there are different doses of this medication, as we'll discuss later. I'll just skip to the contraindications because, of course, we don't want to do any harm to the patients. This is contraindicated in patients with cardiovascular disease, that'll be MI and stroke, uncontrolled hyperthyroidism, glaucoma, concurrent MAOI use, of course, pregnancy and breastfeeding. We don't give this to those patients. And of course, with all these meds, I'll just preface it by saying if they have an allergy to the medication, it's obviously contraindicated. Adverse effects that have been experienced in a significant number of patients will be elevations in blood pressure and heart rate. So with the follow-up exams for these, it's very important to follow these vital signs. And I bring that to the table because we're doing a lot more telemedicine visits now. So I do encourage patients to be able to check their blood pressure and heart rate at home or with another provider if they're doing telemedicine refills for phentermine. Additionally, dizziness, dry mouth, insomnia, and irritability. And there are different degrees of these potential side effects at different doses. It's about finding the right dose for your patient and managing that with their weight loss outcomes. And there are different doses. There's an 8 milligram dose recommended for 3 times a day. There's 15, 30, 37.5. And of course, these medications are tablets. They can be broken in half. Usually they're taken in the morning and avoid taking after the afternoon period to avoid insomnia. Next slide. I'll just read the next bit of the case. Our patient reports 15 pounds weight loss after 3 months on phentermine, and her vitals remain stable. So that's great. She seems like she's doing well. She's pleased with her results, but she's complaining of side effects, dry mouth, mild anxiety, and she wants to know what some other options might be for her. So this is a common scenario we run into in the clinic. The patient's doing well with the weight loss, but is plagued by side effects. So in this situation, phentermine topiramate can be an option because the idea of this is that you can give a patient lower doses of phentermine and still have substantial weight loss benefit, but with fewer side effects by combining with topiramate. So the additional mechanism action is that the carbonic anhydrase inhibitor of the topiramate yields additional appetite suppression. And in the sequel trials for this medication, we saw 9.8 to even 11.5% weight loss versus placebo, which was statistically significant and allowed the medication to be approved. Side effects are similar to those with phentermine, with the additional effects you might expect from adding topiramate, which include paresthesias. Patients tell me they have these sometimes, numbness and tingling of the fingers and toes. And it's really important to ask the patient, is it tolerable? Can you deal with it? Is it worth the weight loss for you? Because many people experience this, but it is not necessarily a contraindication, but patients can tolerate this sometimes. However, it's not for everyone. If someone is, let's say, an eye surgeon, and I had someone with that job, I discontinued the medication because they had such paresthesias. Another effect that can be welcome is dysgeusia, where patients have alterations in their taste, and this may be beneficial for their appetite control. In some patients, additionally, metabolic acidosis can occur because of the topiramate aspect of it, as well as some changes in creatinine. So with this one, we do need to monitor labs where it's not as necessary with the phentermine. Interestingly, with the combination medication, the phentermine and topiramate, cardiovascular artery disease, or CVD, is actually not a contraindication. And I bring that to the table tonight because I want you to know that this is a way to sort of get around some of those prior authorization issues you might have, because it's not contraindicated with cardiovascular disease, but the other side effects, contraindications, are similar. There are many doses. You can see here that half of them are titration doses intended for 14-day use to make sure the patient can tolerate that lower dose. And if they do well, they can be given a treatment dose followed for 12 weeks to determine if they have efficacy with regards to weight. And then if they do not, they can receive a higher titration dose and then another treatment dose. Next slide. Again, going into earlier medications, orlistat, this is available both by prescription and over the counter. The mechanism is a lipase inhibitor. So when patients take this oral medication with a fat-containing meal, the patient then absorbs about 70% of the fat in that meal, and the 30% that remains stays in the GI tract, and that goes into the stool, which gives the side effects of fatty stool, fecal incontinence, diarrhea. So patients should be forewarned of this, but it's also considered to be one of the reinforcements that tells patient, you did not know that this was a fatty meal, but you have the side effect. So maybe if you have less of this, you'll have better outcomes with weight. So it not only comes from the decreased fat absorption, but also some of the behavioral mechanisms which remind patients to eat less fat. The weight loss was about 8 to 9% weight loss at 1 year with 3 times a day dosing with meals that contain fat. Next slide. So next case, we have DA. This is a 54-year-old, 54-year-old lawyer presents with a 20-pound weight gain over the last year. DA states that since his office began sharing space with a catering company, he has found it difficult to avoid the baked goods that are in the lunchroom daily. His weight is also making him feel down, and he's worried that he may develop medical problems, though he doesn't have any yet. Your partner gave him phentermine for 2 months, and while his appetite was suppressed, he still describes intense cravings for the sweets that are so close to him, and he has not lost weight. He has no known medical problems, takes no medication, and has normal physical exam and labs. Next slide. So this is a situation in which I would consider, we had essentially suboptimal results with the previous medications. I would consider something that has a different mechanism. So the mechanism action of naltrexone bupropion is the naltrexone is an opioid receptor antagonist, and the bupropion is an aminoketone medication. And it seems like an interesting combination. Why would one use this? Well, the bupropion aspect actually goes to the alpha MSH pathway that increases satiety. So when Dr. Coley went over that pathway for either anorexigenic or orexigenic messages to eat or not eat, this actually increases the satiety. So it tells patients that are not as hungry and they eat less. And the naltrexone really goes to that mesolimbic system to decrease cravings and desire to eat. So that's the type of patient this might be ideal for, but decreased appetite in 2 different mechanisms. And the total body weight loss, depending on the studies you looked at, because this was done both by impressive studies by Greenway and also Dr. Wadden, they found anywhere between 5% weight loss and 13% weight loss at 56 weeks versus minimal weight loss with placebo. Side effects come as would be expected from the separate 2 components, most commonly nausea, also changes in stool, loose stool, and constipation, as well as some constitutional side effects of headache, dizziness, and insomnia. The contraindications are, again, what you would expect in patients who would take these 2 medications separately. Unstable mental health illnesses, concurrent MAOI use. Of course, this is an opioid antagonist. We can't take it with opiates because of the bupropion component, seizure disorder, eating disorders, and abrupt discontinuation of alcohol and benzodiazepines because of the naltrexone component. Of course, again, pregnancy or breastfeeding. It's recommended, again, to discontinue if the patient's lost less than 5% at 12 weeks. And you can see the dosing basically is a 1, 2, 3, 4. Every week you would increase the medication dosing to both the patient's tolerance, with nausea being the #1 reported side effect, as well as their weight loss. And so next slide, I think I need to make this my last slide, I'm afraid. This is actually a patient of mine that I did prescribe this medication to. After 4 weeks of bupropion, he reported that he was able to titrate up to 4 pills a day. He was no longer making trips to the lunchroom or snack room, and he lost 10 pounds, his mood has improved, and the patient still continues to do well. Thank you.
Thank you. I'm going to continue. We're going to go on to GLP-1 receptor agonists. So this is both the liraglutide at the 3 milligram dose and the semaglutide at the 2.4 milligram dose. Overall effect will be appetite suppression. It does slow gastric emptying. You'll see a total body weight loss with liraglutide. You'll see about 8% over 56 weeks when you're at the maximum 3 milligram dose daily. And semaglutide, you'll see a 14.9, so 15% on weight loss at 68 weeks. And so both of that is compared to about 2% with placebo. Adverse effects are hypoglycemia, constipation because of that slowed gastric emptying, acute pancreatitis. So we do check lipase periodically, and cholelithiasis. So again, we would do LFTs, bilirubin. Contraindications for GLP-1 receptor agonists, and this is for the whole group. You want to make sure they don't have a personal or family history of medullary thyroid cancer or anything under the MEN2 umbrella, and then pregnancy or breastfeeding. Dosing, so liraglutide week 1, you start off at 0.6 milligrams per day, and you titrate up to 1.2 in week 2, and then 1.8 week 3, and then finally week 4 and beyond, you're at the maximum dose of 3 milligrams per day. Now, if you don't see that 4% weight loss by 16 weeks, that's when you can, decide that liraglutide maybe is just not working with this patient. And to try a different one. Most of the time, usually a second medication is not added on. Beverly can speak if she does it differently. It's just a different medication is likely better. Semaglutide, the dosing, so you start off at 0.25, which is non-therapeutic. It's just a starting dose. You're going to do that weekly for 4 weeks, 0.5 milligrams weekly for 4 weeks, 1 milligram for another 4 weeks, and then you're at the 2 milligram dose. 2.4 milligram dose weekly afterwards. And then setmelanotide. So this is very specific. This is for MC4R receptor agonist. So we talked about that kind of briefly in the pathway, but what happens is this is a genetic disorder where patients who are 6 years or older have obesity secondary to a POMC deficiency or a PSK1 deficiency or a leptin receptor deficiency. So any of those alterations can cause excess obesity starting at a really young age. And so this medication has been approved for daily subcutaneous use. The dosing is different based on age. So this is really specific, but between 6 to 12-year-olds, you want to have them go 1 milligram every day for 2 weeks, and then 2 milligrams every day, and then 3 milligrams. It's going to be based on their tolerability. If they're older than 12 years old, then you can start off on the 2 milligram dose and then titrate up to 3. You want to monitor for GI side effects mostly, so nausea, vomiting, headache, hyperpigmentation, and priapism. So efficacy, in this case, you are not checking for weight loss after 4 months. You have to wait a year to really assess if this is working for your pediatric patient. So if they've not lost 5% of their baseline body weight or 5% of baseline BMI, because we know that weight is calculated differently in a younger age set based on their weight curve, so less than 18 years old, then you're going to discontinue this medication. Apologize, that's the brand name of it, as it is not working for them. And tailoring pharmacotherapy. This is really the fun part in clinical medicine, is finding out what else you can also address by giving them these medications. So obviously diabetes, you have a wide range of medications that you can give, but GLP-1 receptor agonists have shown a really high total body weight loss. So that would be ideal to be able to give to them. If somebody has concomitant depression, then you have an option of naltrexone, bupropion. If they have migraines, you know that Topamax is a medication we give in general for that. So giving them phentermine topiramate would be great. It can to hit 2 birds with 1 stone. Night eating syndrome, and this is when patients binge after their last meal of the day in the evening and consume about 15% of their total calories for the day in that one setting. And for them, topiramate does work. Also addressing, there's a lot of psychological causes. And so it's great when patients like this also see a psychologist concurrently to address a lot of these reasons, because medications won't work alone. And then antipsychotic induced weight gain, metformin has shown a lot of efficacy. So, these medications, if you recall, the indication was patients who have not achieved their goal weight following bariatric or endoscopic procedures, or if they've experienced weight regain after these procedures. So these medications, when combined with intragastric balloons, which are in the US FDA approved for 6 months, when you combine a balloon with medications, there was an excess BMI loss of 40 versus the intragastric balloon alone saw BMI loss of 20 at 12 months. Endoscopic sleeve gastroplasty saw a 25% total body weight loss versus 20% of ESG alone at 12 months. And then bariatric surgery. So this, if you combine medications with sleeve, you saw a total body weight loss of 28% versus 22% with just the sleeve procedure alone at 6 months. And then these are the off-label medications. I won't go into them for time's sake, but as you can see, you want to take notice of their total body weight loss of each of these medications. And while it's comparable, it's not as high as the medications that have been FDA approved for weight loss, but it's still a viable option, especially if you have patients who are not where insurance is not approving them. You have metformin, you have the SGLT2 inhibitors, pramlintide, and then the GLP-1 receptor agonists.
Holly, I'm sorry, Sindora, sorry to
What's
interrupt.
exciting is what's coming up. So we have tirzepatide, which has been really exciting for a lot of people within the field. This is a GLP-GIP dual agonist, and it's currently FDA approved for diabetic patients. The effect is similar in terms of GLP agonists, where you'll see delayed gastric emptying, greater satiety, decreased hunger, increased energy expenditure. It's a weekly subcutaneous injection. Side effects, same nausea, vomiting, diarrhea. And in diabetics, there was a weight loss of 7 to 9 kgs, so about 18 to 20 pounds. And there's currently, there's been a couple trials already done, Surmont 1. In that trial, they saw a mean percentage change in weight was 16% with the 5 milligram dose of tirzepatide. They saw patients lose 21% with the 10 milligram dose and 22.5% with the 15 milligram dose versus 3% with just placebo alone. There is a Surmont 2 trial currently underway, and we should get those results in April of 2023. It's expected to be approved following those results. And then another medication that is close, hopefully to the finish line as well, is cagrilintide. This is an amylin analog. It also causes delayed gastric emptying, resulting in greater satiety. Also a weekly subcutaneous injection. Anytime there's delayed gastric emptying and something sits in our stomach longer, you do experience those side effects of the nausea, vomiting. Initial studies show that patients experience a 6 to 10% total body weight loss versus 4.5% with liraglutide. So total overall, they lost 6 to 10%. And then when in comparison to liraglutide, it seemed like it was more like 4.5% versus the 1.8% of patients that lost, 1.8 total body weight loss with liraglutide. There's 2 trials. One, Redefine 1, it's a 68-week trial, started this month, and they're going to see the efficacy of combining cagrilintide and semaglutide, and see the total body weight loss when combining these medications to patients versus the 2 agents alone. And then Redefine 2, that's going to start in 2023. And they are going to assess the combination of cagrilintide and semaglutide in patients who have both obesity and diabetes too. So we'll see for which indication it gets approved for, and if it's recommended to combine it with semaglutide or if it's efficacious on its own. Other medications that are in the pipeline, a lot of these are in phase 2 trials. So we have a lot of dual and triple agonists. So we have pemvidutide, which is a glucagon GLP-1 receptor agonist. These I'm just kind of mentioning mostly names because just to kind of familiarize ourselves with it. We'll see more as studies kind of pop up as these are really early in the stages, but that way we have something to kind of follow over the next probably year to 2 years. Then we have BI 456906. This is going to be a GLP-1 glucagon dual agonist. And recently at Obesity Week, Beverly was mentioning that the buzz has been about triple agonists. So we see a GIP, glucagon, and GLP-1 receptor agonist, retatrutide, which is currently in phase 2. Two other oral GLP-1 receptor agonists are being developed. We have danuglipron and then LY3502970. And then we have another oral option of semaglutide, currently in phase 3. And then instead of agonists, we have a monoclonal antibody infusion, bimagrumab, that blocks activin type 2 receptors. A recent study in JAMA in 2021 showed that those that received bimagrumab every 4 weeks for 48 weeks lost 20% of fat mass and gained 3.6% in lean mass. The mechanism through which this works is it increases insulin sensitivity, increases energy expenditure. And the way that the obesity field is moving is that more medications they're looking towards developing more medications that either increase lean mass or increase energy expenditure versus just agonists alone. But that seems to be the latest direction. And then this was, just a primer. There's so much that goes into tailoring these medications and making sure that they work for your specific patient. So if you want to look into further resources, Obesity Medical Association is a great website that has a ton of resources. Obviously, Tri-State Obesity Society, the Roots lecture is great. We will be starting to have in-person events for mentoring, as well as more educational events, and then also just meeting with different people, whether it's in academia or private practice, so that way you can understand the wide spectrum in which you can practice obesity. There's a bunch of books, textbooks. One of the earliest ones is the Handbook of Obesity. And then the Blackburn course of obesity is kind of a very popular course that allows you to also qualify through getting enough credits where you can sit for the obesity boards, which is either through a fellowship, a one-year fellowship, or you could accumulate credits over a year that allow you to be eligible to sit for the boards. And you can find more information at abom.org. But yeah, any questions or anything?
Thank you, Sindura. That was wonderful. We actually have several questions in the chat, and I want to be mindful of everyone's time. So I'm actually going to have you kind of come back and make a comment on hypoglycemia risk with GLP-1s. We have one of the audience members commenting that there's not really a risk unless there's another glucose lowering agent. What is your experience?
Yeah, I agree. I think the risk is obviously increased when a patient is concomitantly with some other medication, but unfortunately, we have seen patients suffer hypoglycemia with GLP-1s. I don't know if because there is increased insulin sensitivity that it causes, but we have seen some patients experience the symptoms of hypoglycemia. So it's important to note that that can be a reason to stop that medication for some of them, especially, yeah.
Right, yeah, I would agree. I think in the trials, the incidence was 1%, maybe even less than that. I think it was about 1%. So it can definitely happen, but it's very, very rare. Let's see. Kanan Shah asked, what are your thoughts for use of Mounjaro for obesity in patients who do not have diabetes? So using that as off-label. Are you doing that right now, Sindura?
Yeah, people have been. I think it's, you can use any of these medications in an off-label manner if one, insurance approves it, but also if there's availability. I think there's been a large decrease in the supply of Mounjaro. So if you are able to get it for your patient, that's great. I think that as long as the copay and is manageable for the patient, then I think it's okay to definitely use it as an option. It's just tough because it's just not FDA approved.
Great. And then Dr. Katz, you want to go ahead and ask your question?
Yeah, good evening. Thank you for the presentations. Are you able to prescribe medications like Ozempic or Victoza to patients that have no coverage for the classic Saxenda or Wegovy, while not available, but may be available in the future?
Yes, so yes, it's been variable most of the time. Sometimes it's just a pan denial. So once a patient is denied for one of them, sometimes we just see them be denied for all of it. However, some patients' insurance, and I don't know insurances that well, so definitely, Beverly, you can chime in if you'd like. But sometimes they are approved for some of the GLP-1 agonists and sometimes not for the other ones. So it's just, I feel like a crapshoot with insurance companies and what they decide to approve and don't approve. I think that if you have the time and patience, run everything through one after another. And if the insurance approves one of them, great. And then you can always see if down the line, if they're able to, maybe get on their spouse's insurance or, give those options because maybe there's further coverage with that. But yeah.
Yeah, I'll add to that it's a crapshoot. I agree with the different insurances. You can't really predict what's going to be covered. I'll say in the past, like 2019, we used to be able to get Victoza and Ozempic for like pre-diabetes, hyperglycemia, metabolic syndrome, insulin resistance, other diagnosis codes that were not E11 point whatever, not the diabetes codes. Nowadays, we can get it off-label for our patients only if the insurance company doesn't even request a prior authorization. So as soon as we see that there is a prior authorization requirement for that medication, usually that prior authorization will only go through if they have an E11.9 diagnosis, so that type 2 diabetes diagnosis. And I have tried things like diabetes of NOS or insulinopathy or other E13.9 diagnosis codes. None of them go through. So if your patient's insurance doesn't require a prior authorization for these GLP-1s, then you probably can get them in off-label for people with or without diabetes. That's been our experience. It is 6:32, so if Dr. Coley, if you can stay on for just a few more minutes, that would be really great to answer a couple of more questions. Samuel asked, what is the thinking about the use of GLP-1 agonists in patients with binge eating disorder?
Yeah, I think this is an important question, so I'm glad that you asked. I think identifying eating disorders is super important because a lot of these medications can sometimes worsen them. So with binge eating disorders, with anorexia and with night eating syndrome, I think it's important that we have them be assessed by a psychologist or psychiatrist as well. Note how long it's been since this eating disorder has been active, and then have them more regularly visit with the nutritionist, more than us actually. We can continue to monitor how they do on these medications if we decide to start them. I think in some of them, it is a good idea. It does help the patients, but it also, we have to be mindful of their 24-hour food recall. And I think nutritionists are more useful in this setting to ensure that they're not using this to kind of go back to their old methods. And we do want to make sure that they still follow with the psychologist throughout the whole path as well. It's the same as with having them undergo a bariatric surgery, because that's also a way to kind of embed them in, anorexia, or allowing them to binge and then be anorexic. So no matter what, you need to have a concomitant psychologist and nutritionist. And then for some patients, if their eating disorder is too recent, then I think it's best to wait on the GLP-1s and focus just on nutrition. And then down the line, if you feel like you can add a medication, then that's fine. But I think a lot of times approaching with nutrition is a good first step if their eating disorder is more recent. And then I'm able to see the chat. Go ahead, Beverly.
Can you see about the setmelanotide in clinical trials comparing anti-obesity meds, cetera?
Yeah. Yeah, so also a good question. I will be honest, I've never prescribed setmelanotide. There is genetic testing that is free and available for these patients. We do have genetic swabs that we're able to give out to them, and then we refer them to a website which tells them how to send it in and get the genetic testing back. So that's a really great service. I'm like blanking on the website right now. Do you happen to know?
It's Rhythm is the Prevention Genetics is the group, and Rhythm is the manufacturer. But if you just Google Rhythm genetic testing, you'll be able to find it.
Yeah, and so if you don't have the swabs in your office, you can direct the patient to go to the website and they can request the swab themselves. And then that's perfect for getting insurance to cover setmelanotide. And then I see the next question, clinical trials comparing use of anti-obesity medications versus sleeves for super obese patients that have a BMI more than 50 and decompensated CHF who do not qualify for heart transplant. Okay, until their BMI of 40 or less is achieved, what do you do and what is your drug of choice? And do you endorse very low calorie and CHO diets? So there are clinical trials for these patients. There's quite a number of trials that go into addressing, decreasing, getting patients into an ideal weight for not just heart transplant, but say if they want to undergo knee replacement, hip replacement. For a lot of these surgeries, when patients are super obese, that's a huge risk factor. And so there are plenty of clinical trials. I think, so it just depends. You're going to do the same evaluation that you do for any of your patients, and you go through the same way, getting their history, getting their labs. If you want to look at medications at the highest efficacy, then, there are the GLP-1s, if they're approved for those. Otherwise, you approach these patients similarly as you do your other patients. And I think we've been able to optimize so many of these patients so they can undergo their procedures, which is exciting. But again, I would approach them the same way you do your other patients, and then try obviously to start with the medications that have the highest efficacy percentage, if it makes sense for that type of patient. And then in terms of very low calorie and CHO diets, so there's different diets that we prescribe, but you want to, so very low carbohydrate or low calorie diets, we don't do that. What we do is we make sure that they have a moderate protein diet. So it ends up being about like 0.6 to 0.8 grams per kg of their weight that we recommend they take in. And then we recommend about, I think, 80 milligrams of carbohydrates per day. So not very low. Everybody will, everyone has a different diet preference that they kind of prefer putting patients on. And I think they all work in their own ways. I think it's just about what you feel like your patient can stick to long term. I don't know if Beverly, you have different experience, or if you guys have a
Yeah, I think the road to transplant is kind of unique because of course, obesity is a chronic disease, but the road to transplant is a very specific time frame. So sometimes what we do is a very low calorie diet, and we do use medications that we may understand will not be available for them forever. Maybe like Mounjaro off-label for 6 months or 3 months, and kind of get us as far as we can, because there's such a specific time frame for this intervention. So we will be more aggressive on that respect. I want you to go on to Alex's next question, and then we'll wrap up so the night doesn't go too long for everyone. Again, thank you for joining us. So Alex asked about prescribing phentermine 8 milligrams, the Lamara dose, and how many days would you take it? Do you use a TID?
Yep. So you do. It's normally prescribed TID, and that's completely fine. You just want to make sure that their last dose of the day is not too close to bedtime. Try to aim for like 4 to 5 p.m. Just because the side effect for phentermine, because it is a stimulant, can sometimes cause insomnia, but we do see that less with this low dose, but it is recommended TID, and especially for those patients that take the long acting, we often see them start to get hungry in the evening. You know, you come home from work and you binge on some food after work because that's your relaxation decompression time. So in those patients, it might be better to do Lomira instead, TID. Or they can take their morning phentermine a little bit later, like an hour later, see if that can counteract that kind of normal binging that most people do when they come home after work.
Perfect. Wonderful. So if anyone
Oh,
else
sorry,
has
Beverly, we
further,
can't hear you.
oh my goodness, is this any better?
Yeah.
Okay. Anyway, thank you everyone for joining us tonight. If you have further questions, you can reach us at tristateobesitysociety.org. And yeah, thank you
Yeah.
again for your evening.
And also put my email in the chat as well. I know that we kind of rushed through, but I really appreciate everyone for coming. And then, yeah, any questions? And also, I'm so thankful for the Tri-State Obesity for doing these Roots lectures. We're definitely going to have in-person events next year, so please sign up for our emails and we won't spam you, but I think it's a good resource. But thank you guys so much for coming.